So we're here today with Harrison Reed, who's an American physician assistant. He's speaking at the AAPA this year in New Orleans. So thank you for coming, Harrison.
Thanks for having me.
I really appreciate it.
Happy to be here.
So my first question for you is, how did you decide to become a PA?
Well, I found out about the profession when I was in college, I think my first or second year of college, and I always knew I wanted to be in healthcare. It was just a matter of how I was going to apply that. The PA profession really spoke to me because there's a lot of flexibility involved with it, and I kind of saw myself doing a lot of different things throughout my career. So I didn't want something that was going to pressure me to kind of pigeonhole myself in any particular specialty, field, or setting, and the PA profession kind of spoke to me in that way.
Excellent. And how was your experience in PA school?
I loved PA school. It was some of the best years of my life. I was at the Yale Physician Associate program, and it was fantastic. I think it's hard work, but it's great when you have time just to focus and study and learn about the things you actually enjoy. And then PA school always has those extra opportunities, those extracurriculars, those other areas that you can really engage. And that was the kind of stuff that got me really excited during PA school.
How did you get involved with your PA school in terms of extracurriculars?
Our Yale's PA program was very connected to the medical school and to the greater medical community. They do a lot of interdisciplinary stuff there. So, for instance, we had a free clinic that was completely student-run. It was supervised by grown-up clinicians, if you will, but students had every role in the clinic. That included nurse practitioner, medical students, and PA students, and that was a way to kind of get everybody in one place working together at a really early phase in their career, and also to do something good, to provide free medical care to people who otherwise wouldn't be able to afford it.
I know that PAs are notoriously multi-passionate. So what are some things that you enjoy doing outside of clinic?
Well, writing is one of my big things. So I write for fun, I write professionally, I'm an editor, I edit JAPA, and other than that kind of stuff, I like to run. Any kind of race, any kind of distance is interesting to me. And lately I've been traveling a little bit. That's the great thing about being a PA and having a non-traditional schedule, is you can kind of get some chunks of time off. So I've been to Europe a few times in the last year, and just trying to kind of catch up on some of the exploration that you might miss when you're going through all the studying.
Yeah, absolutely. So have you ever traveled to Canada before?
I have been to Canada one time, and it was actually for an AAPA conference. It was when the conference was held in Toronto, whenever that was, 2011, I think. It was my first conference ever, and it was a fantastic experience.
Great. Did you have an opportunity to speak to Canadians, or were you able to find us?
Well, at a conference like that, you blend in. But yeah, that was the great thing about that Toronto conference, was it kind of brought the professions together from both sides of the border. And I thought that was a really great way to sort of engage in an international discussion, but also to have a lot of common ground.
What are one or two things that you like about Canadians or about Canada?
Well, every Canadian I've met is one of the most polite people I've ever met. It seems to me that Canadian PAs have really taken ownership of the profession and are trying to really move it forward. I know that it's not as large in number of Canadian PAs, and also I don't think it's as old as the profession is here. So the fact that it's progressing so rapidly is really admirable to me. It's nice to know that we have this this parallel community of PAs in Canada that's working really hard to move the profession forward and to give good health care to people.
What would you say to someone that isn't familiar with PAs about what we do?
I would say that we're healthcare providers that practice medicine first and foremost. We have different training than physicians, and so we operate differently because of that. We don't have regulated, formalized, and mandatory residencies, so even though we can work in every specialty of care, we do so in collaboration with physicians that are specialized or not. And I think that collaborative relationship is great because it gives us a lot of safety and flexibility, but it also allows a pretty wide range of autonomy depending on the particular PA. I think it's important for people to know that PAs are always learning and growing, and an experienced PA can do a lot, and a lot more than what people expect, I think.
And what is that relationship like with the PA and MD?
Well, that varies a lot by practice setting. I think a lot of people view it in one static way, and that's just not the case. It really depends on the particular individuals. It depends on the setting, the specialty, and the type of work that they're doing. I think that professionally, from a macroscopic standpoint, we have a good relationship with physicians, with the physician profession. But some people work pretty independently, and there's a lot of PAs out there that rarely, if ever, see the same patients as the physician, or consult the physician on a regular basis. I certainly know PAs that are the only medical provider for their community, and so that relationship with their physician is pretty distant, literally and figuratively. But I think people need to know that there's a big scope here, there's a big range, and there's a lot of individual situations that dictate what happens.
So is there a big difference between when you're a brand new, fresh grad, it's your first time working in a specialty, versus if you're well seasoned and you've had several years of experience?
Well, absolutely. I mean, like anything, I think people will naturally get better the longer they do something. But it's really a big responsibility of every PA to make sure that they're putting themselves in a position both to be successful and to be safe for their patients as well. There's certainly going to be settings out there that somebody could find themselves without the resources and the backup that they need. There's just too many variables in the world. There's not enough safety nets inherently out there. So PAs need to be responsible, and I think we are. I think we do a good job of teaching young PAs that it's their responsibility to look out for their patient, bottom line. So even though some people are intimidated by a new practice setting, it's important just to set up enough safeguards to have enough backup to feel like you're secure for your patient's sake. And then from that point, you can really grow. And after a while, I think people can really feel where their abilities are growing and can kind of know what they know and know what they don't know. It's kind of a cliche, but it's really an important concept.
How would you describe what your practice is like?
Well, I work in critical care, so that's a little bit different than a lot of outpatient settings. By definition, our patients are all really sick. It's usually pretty acute, although a lot of them have chronic illnesses as well. So in my particular practice setting, we deal with even the most acute of the critical care patients. It's a resuscitation unit, so our main mandate in the world is to get the sickest patients into our doors as fast as we can, resuscitate them, and get them to where they need to be, whether that's the operating room, whether that's an ICU, or any place else. So it's a fast-paced environment. The patients are very complex. Most of them don't have just one disease or one organ system that's involved. So it's a lot of seeing the interplay of an entire human body and what can go wrong through the course of a disease. So it's very interesting from a medical standpoint. It's really interesting from a human standpoint. All of these people are seeing me on their worst day. All of these families are seeing us on one of their worst days, and they're often blindsided by the situation that they're in. So even though the technical aspects of the medicine can be really interesting and fun, the human side of it plays a big role as well.
Mm-hmm. And can you walk us through a typical day for you in critical
Sure.
care?
It was a 12-hour day at this point. A lot of ICUs are staffed by PAs 24/7, which is the case with mine. So it's either a day shift or a night shift, but either way, in the door at 7, and then there's no script for the rest of the day. If there's patients that are already there, I'll get sign out from my counterpart that was on the shift before me, and then we just let the patients come to us. We admit both in-house patients that are decompensating, and then we take transfers from all over Maryland, DC, and further than that. So it can vary a lot. We might admit 10 patients in a shift, and that's a really busy day. So what I personally do is when a patient lands, I see the patient first. I see them with our team of nurses and techs. We draw labs. We do a lot of diagnostic work right off the bat because the patients are so sick. So we'll usually have a full panel of labs sent. We'll examine them depending on how sick they are and what's going on. That can involve procedures, ventilator management, managing stuff like vasopressors. We do a lot of more advanced therapies like ECMO, and we do cannulation for ECMO in our unit. So I'll often assist with those procedures or perform the procedures myself depending on the situation. And, it's just unscripted from that point forward. So whatever the patient needs, the PAs and nurse practitioners that I work with get it done.
So do essentially the PAs and NPs function very similarly to the way that physicians would in that situation?
Yeah, this unit also has a physician that staffs it at all times. The breakdown of labor can vary a lot. If there's a lot going on, we might just split the work up completely. If there's one patient coming in that's very sick that needs a lot of attention, I might do a procedure while the physician calls a consultant. We may have a code running where I can run procedures, do a bedside echo, and make sure that our chest compressions are effective and that our team is rotating out effectively while a physician is consulting with a specialist, or while a physician is otherwise running the code. Or maybe I'll go and take care of another sick patient while our physician is taking care of the rest of the unit. So the work varies a lot, and the breakdown of the work varies a lot. The most important thing through all of it is that we have to work really closely as a team. We have to communicate really well and know what the other person's doing. And beyond that, there's not a whole lot of rules.
Okay, so is there a huge difference between what a PA and NP would do in the setting of critical care?
So that, again, varies a lot by practice setting. I think in the best situations, a new PA works very closely with a physician, and then as they get more independent, they do look very similar to a physician role. Often a patient can't tell the difference between a PA and a physician, and that's not because the PA doesn't introduce himself or display their job title, because they always do, but it's because the role can really mirror that of a physician. Critical care is tough because nobody's in a silo. Even our team works with other teams all the time, so it's really tough to isolate one person and say, you do this all the time, because in reality you're interacting with multiple people constantly in critical care.
Mm-hmm. Mm-hmm. So I remember reading your blog back in 2012, and I remember just remarking that it was very different than the other PA blogs that were out there. A lot of them focus on, how to deal with the CASPA statement application, how to apply to PA school. Can you describe your style of writing and how it's evolved since then?
Yeah, I always thought writing a blog as a student was a difficult thing because by definition, you're not an expert when you're a student. In fact, I think sometimes we get into PA school and we want to just tell everyone about our experiences and assume that applies to everyone. The truth is, we're novices in PA school, and we're only exposed to a really narrow sliver of the PA world at that point. Our perspective is really narrow. So I did do some of that kind of how-to, and here's how to survive PA school type of thing early on a little bit, but I really tried to get more to the emotional core of what it was like to go through some of the experiences that I had in PA school. I really wanted to tell people about interactions I had with patients and what that meant, whether that was exploring my own prejudices and those of my team and trying to, grapple with dealing with homelessness in New Haven, or whether that was about, experiencing some new culture completely, like when I did a rotation in Kampala, Uganda, or in eastern Kentucky. Every one of those experiences sort of gave me a clinical lesson, but also a life lesson, and I really wanted to drill down to those more universal themes and present something to readers that was relatable, not because it was generic, but because it was universal.
Mm-hmm. And how do you balance being able to speak to your experiences and maintaining patient confidentiality?
Yeah, that's tough, and I'm surprised I don't get that question more, to be honest. The truth is you have to be incredibly careful to respect the human beings that you're talking about. I think there's generally 3 ways that you can do that when it comes to being a writer in the healthcare setting. One of them is to just have the patient's permission. That's the easiest, but it's not always possible. That takes planning ahead of time. It takes a patient that knows what's going on and that is able to give you an informed decision like that. The second way is to write things in a universal sense. You can capture the emotion of a situation without necessarily capturing the particulars. So sometimes you can write in general terms about sort of the ambiguous patient. That's not necessarily a person, but it's an experience that you had. And frankly, the details of the human being themselves, where they're from, the color of their hair doesn't matter as much as the experience and the emotional truth that's going on. And the third way is to composite people. And you'll find in healthcare that you have a lot of the same experiences over and over again. So rather than picking one of those and telling that story, you can composite multiple experiences, put them into one, and then you're not really violating any particular human being's privacy. You're just, again, talking about the truth of the situation.
Mm-hmm. Do you have any tips for anyone or any PA or PA student that is thinking about starting a blog, but they aren't sure about what topic to write about or how to go about starting one?
Yeah, I think that's the challenge of any writer, is to both feel the confidence to present yourself as a writer and also to feel like your content is worthy of people reading it. I think people need to take a little bit of a leap at first, but the truth is you need to find something that makes you a little bit different. And 6, 7 years ago, I think being a PA student was an isolated world. I don't think we were as connected as we are now with social media. It was really hard when I was applying to PA schools to find people that were writing about their experiences as PAs and especially as PA students. That's not really the case anymore. There's a lot more content out there and there's a lot more connection. So I think people need to find a different angle and find what makes themselves unique and then apply that to their writing. That can be scary because that usually means being a little more honest than we're used to being, and it usually means that we're exposing ourselves to the eye of the public, and that's intimidating, but I think that's where the best writing comes from. It comes from taking risks, and it comes from being really honest.
And how do you maintain this air of professionalism throughout all of your social media and your writing?
Well, that takes a little discipline too. Again, I think that is still a balance of being real and being professional. And I always see myself online as a PA, as a professional, as a healthcare provider, and I try to keep that in mind. I mean, we're all human beings. We all like to have fun. We all like to be individuals, and nobody wants to be stuffy. But when we label ourselves PAs or PA students or physicians or nurses or whatever the case may be, we're really presenting ourselves to an entire world as somebody that is inherently trusted and is given a lot of power in the world. People put their lives in our hands, and I think that responsibility carries a certain weight, not just in the clinic or in the ICU, but throughout everything in life, and that includes social media. So, when you think of it like that, when you think of it as you're an inherent leader as a healthcare provider, then I think the onus is really on us to present ourselves that way.
Mm-hmm. Can you speak to how toxic cultures affect patient care?
Yeah, I think that there's not a lot of evidence out there, but the evidence that we do have is pretty clear that treating each other poorly, being bullies in general, is bad for patients because it affects the people around us, sure, and our jobs have a lot of small factors that go into patient care. So if any one of those factors is thrown off by a toxic workplace, then it's going to affect the end result, which is the care that we give our patients. So there's little things just like breaking down communication, and not being able to communicate leads to more errors. It also leads to errors that aren't fixed, even if they occur. So communication breakdown, being worse at procedures because somebody is being uncivilized in the workplace is a documented phenomenon, and ultimately all of this coalesces into hospitals that have really bad care environments or really bad interpersonal environments give worse care. There's been great studies that look at simulations of resuscitations while people are insulting each other, and they don't go very well when that's going on. So if you care about your patients at all, then you have to care about your coworkers and you have to take care of them as well.
There's a big discussion on social media about physician burnout, and I'm sure that's not exclusive to physicians, but what is it about toxic medical cultures that contribute to that healthcare provider wellness? Right
now we're doing a lot of speculation in this area because we're only now beginning to look at this topic as something that's worthy of research and study. That being said, we know that the things that fall under that umbrella of burnout are closely related to a toxic workplace culture. Anxiety and depression, the tendency to quit your job, all of those things that we kind of call this potpourri of things that is burnout, it's all very closely linked to the culture itself. We talk about this in the context of physicians a lot, and certainly there's a lot of nurses out there, and there's been more research on physician and nurse behavior than there has been for PAs, but I think PAs have a very particular role in the world that puts them at risk for different types of burnout and different types of toxicity. We don't have the numbers that nurses do, whether that's in the country or whether that's in the practice setting. Sometimes you're the only PA. There's not another PA around to sort of relate to or vent to. And we don't have that inherent hierarchical power that physicians seem to. They still have some of that old school traditional influence and authority just by the virtue of being a physician. PAs don't really benefit from that. While we're admirable medical providers, we don't have a long history of having inherent authority just because we're PAs. We're seen as team players, and that's the way it should be. But that also means that we're at a disadvantage if somebody's being toxic towards us. We don't have so much of a power play to make. So I think that PAs, while we don't have a lot of data on it, may be at unique risk for burnout and may be uniquely exposed to toxicity in the workplace.
PAs are fairly new in Canada, and like you said, I guess this does happen in the States where sometimes you're the only PA in that facility. It can be intimidating whether you're new or you've been established for a while. Sometimes cliques do form within healthcare environments.
Sure.
And whether there's seniority in the workplace or a power gradient that you do talk about, what's a way to address the us versus them kind of mentality in healthcare?
Yeah, it's so easy to kind of get into our tribalism, and I think sometimes people see that us versus them as an opportunity to bond. Our team can get closer because we don't like that surgery team over there, or maybe, me and this other PA can kind of bond over how much we dislike this other person we work with. And that's very tempting, but it's very toxic. And really, healthcare is great because we already have common ground to bond on. We have patient care. So we don't need to create these artificial divisions between a team to kind of have somebody to root for. We're rooting for our patients at all times. So I think just remembering that we're all going into this building or going into an exam room or going into an operating room for the same reason, and that alone is something to bond over. So I think shifting the perspective from, what can we kind of get our team excited about from an adversarial point to a really cohesive, patient care-centered perspective is important.
Mm-hmm. You also mentioned in your talk about the effect of witnessing destructive behavior. Can you talk to what the effect is on providers?
This has been looked at in a few areas, and there was a great study out of the UK's NHS that looked at thousands of healthcare workers and kind of the effects of negative behavior on them. It turns out that merely witnessing toxic behavior can have some of the same outcomes as being the bully or being the target of that toxic behavior itself. So things like intent to leave your job, basically turnover, quitting, can happen even if you're never actually targeted yourself, because watching people get bullied, watching people be cruel to each other is almost as bad as being the victim of it. It makes you not trust your colleagues. It makes you not trust your workplace environment. It makes you lose faith in your leadership, your administration, for not doing something about it. So all of these things can make the witnesses of this behavior, just as at risk for things like quitting and worse than being the target of it can.
It does cost the healthcare system money. Can you speak to that?
Part of the myth about bullies or toxic people in the workplace is that if they're good enough, if they're smart enough, if they're productive enough, it kind of outweighs all of the negative things they bring to the table, and that's just not true. Because people affect everyone around them with their behavior, you can quickly rack up a pretty big price tag on toxic behavior. And so somebody who's marginally more productive than those around them can give huge deficits to the productivity of everyone that they're mean to, everyone that they bully, everyone that is exposed to their toxic behavior. So if somebody quits their job, it costs a lot of money to replace them, 1.5 to 2.5 times their salary. That adds up pretty quickly just from turnover alone. But there's other things like wasted time and energy. People, instead of caring for patients and being productive in the workplace, they're deflecting, they're avoiding, they're dodging some of this behavior that's going on. So you lose money from those opportunities. And then there's all of the really bad things like medical errors and sentinel events. We think of those in terms of the human cost, of course, but don't forget that it costs money if bad things are happening clinically in your place of work. So there's a big price tag that gets racked up. One group of radiologists tried to add up this cost in their community hospital and came up with about $1 million a year that they could find in money purely lost to toxic behavior. Mm-hmm. And so that was a pretty shocking figure to see, but I think it's actually far higher than that in some of the bigger institutions.
Yeah, I'm just recalling the picture slide that you had of the cockroach in a bowl of, was it bananas or cherries?
It was cherries, yeah.
Yeah, and how the fact that even just having the one cockroach will kind of affect your taste.
Yeah, negative behavior is contagious, and mm-hmm. it magnifies itself. One incident can have a far greater impact than all of the positive incidents that preceded that. So I think it's important for us to remember that this type of behavior can get out of control, and there's things like victims themselves becoming bullies that perpetuates a cycle. So it's something that even allowing a little bit of toxicity in your workplace can end up costing you in big ways in the long term.
Mm-hmm. And can you speak to what you meant by "don't be a buffer"?
Yeah, I think this is a really common situation that people find themselves in. They consider themselves a good person and want to help their colleagues, so when they see toxic behavior going on, they try to stand in the way of it in some way, shape, or form. And I don't mean that in that they call it out. They are standing in the way to deflect it, to buffer it. They may make jokes to try to diffuse a situation. They may try to distract a bully from some of their easier targets. They may end up just trying to do the work that is no longer being done because of the toxicity going on around them. And essentially they're sweeping the behavior under the rug. It's tempting because it seems like the right thing to do at times. In the short term, it makes the situation a little bit better. But in the long term, it covers up the behavior. It protects the perpetrator as much as it protects the victim, and it prevents anyone from actually exposing the problem and then correcting it. So what you'll find is that a buffer, not only are they wasting their own time by spending all that energy buffering somebody, they're preventing the system from correcting itself. So a benevolent intent maybe, but the outcome is not good.
And can you describe that metaphor that you used about the clinical use of buffering and how that relates to
Yeah, I mean, the slide that you're talking about had a bottle of sodium bicarbonate on it. We use bicarb in the ICU all the time, and really, it's a good drug to quickly reverse acidosis, but it doesn't do much. When your patient's crashing on you, you can pump them full of bicarb, and their blood pressure looks better for a little while. Their lab work looks a little bit better. That pH on their ABG looks a little bit better. But as soon as it wears off, if you haven't corrected the underlying issue, that patient is just as sick as they were a few minutes ago, and you've done nothing but buffer them.
How are you enjoying the conference so far?
I love it. Every conference is a new opportunity to meet people, to learn a lot, and you always leave with a few awesome experiences.
Okay, and for those that have never attended the conferences, what can they expect when they come to something like AAPA?
Yeah, I think people don't realize how much fellowship there is here, and just the camaraderie that you feel being in a room full of PAs. A lot of people in their workplaces aren't around big groups of PAs all the time, so there's kind of a cheerleader component to it when you get in a room full of PAs. It's nice to be able to relate to everyone. It's nice to be able to swap ideas. It's nice to be able to kind of see how other people are doing things. So I think that camaraderie and that opportunity to be in a huge room full of thousands of PAs is something you can really only get at this particular conference. It's one of the best things about it.
Mm-hmm. And there's more to AAPA than just the CME sessions. And can you speak to some of the networking events? Or I know that you're going to be at a booth later today, right?
Well, I think tomorrow we'll be at the booth with JAPA. But I think people think of it as a CME opportunity, and there's tons of CME here. I mean, you could probably recertify off of a couple of conferences alone. But for me, the real impact comes from networking with people, from finding opportunities for leadership and advocacy. I think the way that I got involved with JAPA was by meeting people at events like this. We think about it as a learning opportunity, but really it's an opportunity to build things, to build connections and to collaborate and see what we can do as a team.